And good afternoon, you all. I'm Susanna Vacas. I'm going to be moderating this session today. And I wanted actually to start by acknowledging Liz Abramovich, because she actually also helped put this panel together. And so today we're going to be talking, it's this point counterpoint, which is EEG as a number. And it is love it or leave it. So we're going to have two sides to work on. On the love it side, we're going to have Alex Becker, and he's going to be talking to us about how the value of EEG index monitoring, how its value is well established. Alex is a professor and chairman of anesthesiology at Rutgers, New Jersey Medical School. He obtained his doctoral degree in biomedical engineering from the New Jersey Institute of Technology and his MD from the Rutgers, New Jersey Medical School. He went on to complete his anesthesia training at Columbia Presbyterian Medical Center in New York. He's an internationally recognized expert in perioperative medicine. Clearly, he can do the pro and the con, so that might happen. And his research work has been recognized in over 120 peer-reviewed publications. He has also served as PI of numerous clinical trials, including studies sponsored by the National Institute of Aging, where he focuses on perioperative brain protection. On the dark side, it's Dr. Syed Safavinia. He's an assistant professor of anesthesiology at the Division of Neuroanesthesiology at Weill Cornell Medicine, New York Presbyterian, where he serves as associate director of the anesthesiology core residence and the neuroanesthesiology fellowship programs. He earned his PhD in neuroscience in 2012 and his MD in 2014. His current research interests are in applications of intraoperative brain monitoring with a focus on mitigating perioperative neurocognitive disorders. So with this, Dr. Becker, let's just start with this prawn, and then we'll
see what happens.
Do
you see? Yeah, it is there. I just don't see it here. Oh, yeah, okay, everything is here. Okay, good afternoon. So my goal is to show you that brain function monitor, as we have right now, I'm 100% sure that Dr. Syed will tell us that current monitors are meaningless, but in the future EEG would be something great. Nobody can deny that we as anesthesiologists, main purpose of our work is to find sedation level. So it would be ideally to have a monitor which can monitor depth of anesthesia, level of sedation. Nobody can deny this. Main arguments are that current value of currently available monitor, it's not justify, cost is not justify the value we can get. So I would like to show you that monitor as we have it right now, just index monitor, nothing else. I'm not talking about complex DCA and DSA and things like this. This is probably Dr. Syed will talk. My goal is to show that currently what we have, we still have clinical benefit. Okay, just press it, right? Probably this is I think, yeah. No, I can just do it this way. Yeah, so I have nothing to disclose, unfortunately, but this is what it is. Oops. So I think I need to use this. It's not something. So I'm not pressing. It's this one, right?
Yeah.
Oh, slide 2, I can do it from here. Yeah, okay. Okay, most seems to be in the United States or all over the world, physician, clinician, they're not waiting for results of our discussions. They're using this monitor anyway, and numbers are very impressive. When I say BIS, I don't want you to have impressions that it's just BIS. There are other brands as well. It's just most of research it's related to BIS. So I will use this term, but again, it's a generic term, brain function monitoring. So anyway, this technology is used right now in more than 60% of hospital, approximately 30% of cases. Total US market for brain function monitoring. Okay, we have Syed here. Let's welcome. Okay, so total market penetration about 170 billion was million was spent on this monitor in 2024. So something physicians see, and this is what I would like to kind of share with you, what they see, why they're using it now. And they see value in this, they know the cost, they see value. So let's try to figure out what exactly they're using this monitor for. Advantages of moderation have been understood for years. Confucius says was to go beyond is as wrong as to fall short. So what we want to find is a Goldilocks place for sedation. We don't want to light anesthesia, which will lead to awareness. I will discuss this thing. Possibly in my conceptual documented case, you have tachycardia, hypertension. On the other side, you don't want to overdose because you bring all bunch of other problems such as prolonged recovery, postoperative delirium. We kind of briefly discuss evidence of this statement for this myocardial depression, etc. So we want to have a monitor which will help us to keep our patient in this green zone. It's kind of, sounds like a good idea. Let's formalize this discussion. So what's the advantages of this drug? It reduces from, each of these statements is supported by some evidence. So reduce incidence of awareness, it's reduce consumption of drug, faster emergence, less PONV, even postoperative pain is somehow there. Papers on that. It's helpful in some special patient population, especially in elderly, and their overall cost saving. Why not to use it? It's very most argument that cost and resource utilization. Is it worthwhile to spend $15, I think, right now, to get all these advantages? This would be one thing. And there are limited accuracy. People don't believe this number is kind of going back and forth. There are many, but as you can see, this is the issue with every monitor, not just this monitor. So awareness is how this monitor was introduced. So let's start with awareness. I just want to read very briefly. This is one of the first, it is the first description of awareness, and at that time in early 50s, scientific paper been written very different way. Like Dr. Winterbottom, he just documented what patient told him, and she, after surgery, she thought, I remember going to sleep, then she was awakened, the most excruciating pain in my tummy. It felt as my whole body inside were being pulled out. I wanted to cry, and you can read it. I don't want to waste time, but you understand this is not as benign as people think. Awareness, oh, I never had this thing. But whatever it is, it's a horrible condition. And it's interesting, they have an ICD code for treating PTSD secondary to awareness during anesthesia. No, obviously, anesthesiologists, we give this disease. We don't bill for that. You cannot bill for giving disease. It's mostly sort of psychiatrists. But if ICD code exists, it means it's enough of these cases that it's worthwhile to pay people to treat this thing. And awareness is kind of a sexy disease, whatever rarity. Especially in late 90s, early 2000, was a lots of program. Was a movie with Jessica Alba called Awareness, just about that. So it's a lots of shows and things like this. So let's see what actual facts show. Brain function monitoring awareness. From all this study, and there, I think later I'm showing you Cochrane review, brain function monitoring can reduce incidence of awareness by 80%. Overall, from this study. There are studies which contradict this thing. It is probably most famous as Michael Avedon and his group and George Mashour. There are a couple publications where they show, they actually didn't show that BIS, in their case, BIS, reduce incidence of awareness if you compare it with end-tidal anesthetic gas concentration. If you can maintain, according to them, if you can maintain end-tidal concentration above 0.7 Mach, then incident of awareness more or less the same. They repeated the study. It was a lots of criticism, liberal inclusion criteria, not adequately powered, whatever. They repeated study in a group of high risk patient, and they see definitely the difference between BIS and no intervention, and there are some advantages if you compare with ETAC, but it's not statistically significant. So this author, who are both brilliant, they came up with this scheme. They suggest that BIS monitoring or brain function monitoring should be used if you use TIVA. This is definitely enough data. If you use TIVA and you have neuromuscular blockers, then it definitely will reduce incidence of awareness. And most society actually accepted this as a final truth. This is our society, American Society of Anesthesiology, confirms this thing and suggests to use it in selected high-risk patient. And high-risk patients usually C-section, trauma, cardiac patient and so on. The other, it's Association of Anesthetists of Great Britain, the same recommendation. For TIVA, they highly recommend. If you can maintain concentration of end-tidal around 1 Mach, you probably, it's a doubtful. From this point of view, there are other advantages, but I'm just talking about awareness. But if you use TIVA and neuromuscular blockers, so definitely, and in Europe they use TIVA much more cases done with TIVA than in the United States for, I don't know, for unknown reason. And the same, it's Anesthesia Patient Safety Foundation, the same recommendation, awareness prevention, intravenous anesthesia. So this kind of situation when we do, most society agrees that it's a useful monitor. Okay, let's talk a little bit about improving anesthetic delivery. Every parameter, this is Cochrane review of many studies, and I kind of rely, I can't go through, there's hundreds of these studies, so we'll just go with Cochrane systematic reviews, and it shows that it's reduced time to eye opening, extubation, home readiness, PACU stay, and so on. And argument here would be such a trivial, do you really care that the 6 minutes in PACU is saved by using this monitor? It's an arguable point. I think more important, it's not the 6 minutes, but it's a range. So there are some people who will stay if you see ranges here, it's from, let's say, time to home readiness for decimal, it's from 107 to 45. So it's a range. There are some people who will stay really long time, and BIS or brain function monitor can prevent this thing. But one way or another, all this indicate it's useful monitor from this point of view. So let's talk a little bit about use of medication. Again, it's meta-analysis, Cochrane database of systematic reviews. It shows for a propofol, it's 22 microgram per kilo per minute. For a regular case, let's say spinal fusion, when you usually use monitoring, we talk about 400 or 500 milligram of propofol, and this is what it is. It's also for volatile anesthetic, it's also reduced probably about 1.5 bottle of desflurane, and a little less would be for sevoflurane. Next topic which I want to address, where it's definitely shown advantages, it's postoperative delirium. Again, this is review, it's not Cochrane review, it's a review done by a group from California, and Michael Avidan, of course, there, and it shows that postoperative postoperative delirium reduced in cardiothoracic surgical patient by about incidence by about 30%. Why it's, for most of us who don't do cardiac surgery, we kind of don't even know what happened. If they have delirium, it's kind of from humanistic point of view. It's good not to have delirium, but we generally don't see patient in ICU, but the incidence is high and it's costly. And in cost calculation, which I will talk a little bit later, it's entered into the picture. So one case of, to prevent one incident of delirium with current like 20%, you need about $100. One case of delirium, it costs about $2,500. So from this point of view, it makes certain sense. And based on this, American Geriatric Society expert panel, and it's adopted by American College of Surgeons. They recommend use of BIS to prevent incident of delirium. The same with European Society. Actually, their recommendations are stronger. And this is, I just put this picture, ostentatious fashion. It's from Europe. I felt it would be kind of cool to show that Europeans have this sense of fashion sense. Now I want to, let me go back for a second. Now I want to bring important point, which I mentioned before, but I want to emphasize this. Cost and cost-benefit analysis of any monitor, whatever we have right now, would never show that it's cost beneficial. We use it because certain tradition and things like this. And I will want to show you a couple of Cochrane systematic reviews on very common monitor. This is pulse oximetry. Apparently, it was never shown, and actually it shows that there's no improvement with pulse oximetry. Most of this study have been in late 90s, mostly from Denmark, but there are analysis, and it's kind of hard to believe to do case without pulse oximeter, but there's no actual proof, no ever been done randomized controlled study which shows that pulse oximeter does anything good. And a clinician can do it. Supposedly in these studies they did without, and result wasn't different. But again, it would be unimaginable right now. But if you're looking for controlled, randomized prospective study for pulse oximetry, does not exist. How about pulmonary artery catheter? Nothing. Does never been shown that it does anything, not improve mortality, admission to ICU, exactly the same. Actually, there are at least one study, I'm pretty sure was from Columbia when I was a resident there, that it's increased risk of infection. In a way, it's a negative result. Even something like fetal heart rate and uterine contraction, never shown that anything, if any, people argue that it's increased rate of C-section. So again, I want to repeat, when we talk, we're putting some criteria and want to introduce certain monitors, it should be clear. They're not just brain function monitors. There's no monitor ever been shown, EEG. You wouldn't find this study. They never did a randomized control study. However, somehow when we talk about brain function monitor, we want to apply this highest possible criteria. And this is not, I would say it's not fair. Okay, so let's see what we have next. Oh, I want to talk a little bit about cost of this thing. Spencer Liu from Johns Hopkins did this analysis, cost analysis. It's kind of meta-analysis what he did. And he showed, and it's, I'm not going through details, generally shows the total this electrode with all of these advantages. About you will spend $5.5, something like this, if you account for saving in. I don't think he didn't even consider delirium. It's just based on PONV, recovery time, and things like that. Delirium is not part of this conversation, which actually reduce cost even further. How much, it's kind of interesting study, but that by most people probably know, TJ, I think I was part, anyways, they did this survey. They asked patients, how much you're willing to pay to make sure that you don't have pain, you don't have intraoperative awareness, you don't have PONV, and patient willing to pay $34, which is more than willing to pay for PONV. So patient be happy to pay out of pocket this money just not to have awareness. Again, it's for us it's kind of rare phenomenon, but for people who have it, it's sleepless night and things like that. So I think next slide I will show you. Yeah, this is a slide. It's an old study from Karen Domino, which they took a database, closed claim database, and they calculated average payment for cases of awareness. Approximately, it comes out. It's in 2003, something like this dollars. So you convert to current, approximately 250,000 right now average, but I don't know what's the highest. At that time, highest was 1 million for awareness. Depends, it depends on age and things like that. So it's again cost analysis, which I showed before, doesn't include any of this stuff. So it's a cost. No matter at what point you spend this money, is spent. So it should be part of it. So when we arguing about use or not, to use or not to use, to be or not, whatever. So from this point of view, it would be cost effective from all what data presented here. And again, I'm not talking about very sophisticated EEG monitor, which I'm pretty sure Syed will talk about. Again, nobody will deny that it's a reasonable monitor to have when you talk about sedation, but future probably would lie in making it more sophisticated. But right now, this is what we have. We have very simple number, and based on this number, we done clinical decision. With this information, only all what I was talking about, it's true and it's supported by evidence. All right, let's go to, all right. So with all what I said, would you use this device which reduces intraoperative awareness during TIVA and possibly during general anesthesia, reducing anesthetic use, reduces recovery time, minimal, you can argue. Again, what's important there, it's a range. For some people, majority will wake up no matter what you do. They will wake up within, I don't know, 10 minutes, something like this, but they always would be outlier, which can be improved by using this monitor. Reduces incidence of postoperative delirium, improve patient satisfaction, reduces PONV, and cost approximately $15 per patient. If you in 340B hospital, like I am, it's $11. One way or another, I think what data I presented support use of current monitor. Again, it would be, you will hear and probably hear, they're considering special courses, and it's a very active area of research to use burst suppression. Dr. Syed will tell more about that. In the future, it's good. But let's say, I don't know, 30 years ago, what, 5 minutes or finish? I will finish in next 2 minutes. 2 minutes, good. But now I lost my thoughts. So I mean, it was such a brilliant thought. I mean, oh yeah, let's say 20 years ago, if you have VHS, it wasn't ideal device to play movie, but people benefited from this. Right now we have a streaming. If you wait for 20 years to see movie on streaming, yes, it's a better technology. But meanwhile, 20 years people had fun. I'm not proposing to have fun, but I'm proposing that there are clinical value right now. What would be in the future would be better, I'm pretty sure. But even what we have right now, this is monitor, which I will advocate and I use in my cases. No, my practice is mostly limited to neurosurgical cases when you have a long TIVA inject. I mean, for me, it's a must monitor. But even if you don't do that and use neuromuscular blockers, there's absolute justification to use this drug. And my last statement, I don't know, it's my father's wisdom, that it's better to be wealthy and healthy than poor and sick. Sure, in a better monitor would be better, but this is what we have right now, and I believe it has a great clinical value. Thank you.
Yeah, sorry, I know how to make an entrance. But I think it's because I figured this talk could just give itself. I have nothing to disclose, and really, here is my evidence. This is a Jello mold attached to a BIS monitor. There's a flash of light, and the Jello mold is waking up, dangerously so. Maybe a little better. Nope, just kidding. Even worse. So, hopefully, we would agree that this is not a case of unintentional awareness. But if we're using these monitors for this purpose, I think we have a lot to reconsider. So, a disclaimer. I'm not arguing against the use of intraoperative EEG, just the process indexes. And this is why, and I've shown this slide before several times, but it's because, while we have complicated EEG and we want to distill this into something that is clinically useful, when we do so, we make a lot of assumptions. We take some frontal EEG, we apply some filtering algorithms to give us some nice smooth EEG. From there, we apply some burst depression algorithms and maybe a frequency transformation to get us power spectral densities and density spectral arrays. And now we have all these bells and whistles of spectral edge frequencies and EMG activity. How do they figure that out? Artifact, signal quality index. And then there's some more proprietary algorithms that get put together to ultimately get you your wonderful EEG index, your BIS and your PSI number in the case of the BIS and the SED line, respectively. And so hopefully what you can see from all of this is that if you are relying on these indexes to make your clinical decisions, you are first relying on an approximation of an approximation of an approximation of EEG activity. And secondly, you are also the most time lagged in making your clinical decisions from what's actually happening at the neuronal interface. So, are these indexes reliable? This is evidence given from Michael Avidan on the IceTap website, and this is a patient undergoing cardiac bypass. You can probably tell by the flat arterial line, and the BIS monitor in this case is saying, well, this patient is over-anesthetized. And if there are those in the room that can read the EEG more closely, I mean, the EEG looks actually kind of beautiful. And if the index number, the BIS number, was the only feature that one would use to titrate their anesthetic, I would be really worried that this patient, in order to get that number into the appropriate range, may go to a dangerously low anesthetic. And you don't have to take Michael Avidan's word for it. You can reproduce this. I can reproduce this in my own OR. This is me during a kidney transplant in a patient while I'm running a BIS. And you can see that this patient has really lovely continuous EEG activity, has some alpha activities, has got a spectral edge of 10, and the signal quality index is fairly respectable, but the BIS number says 23. And so my decision should have been, given the number alone, to go down on this anesthetic to I don't know what end. And I think that's the concern that we have. I think part of this is because our EEG index monitoring is not context specific. So, this is the spectral signature of propofol, where you get this beautiful alpha delta pattern, and that's, quite lovely. It's a wonderful drug, and it works primarily at GABA receptors. Similarly, volatile anesthetics, which also have actions at the GABA receptors, can give you this spectral profile, and these are usually give pretty concordant results with what an EEG index monitor would tell you. But these aren't the only anesthetics that we give. If you are giving somebody ketamine, for example, you're going to readily see problems and discordance between what you have in the raw EEG trace and what the EEG index is telling you. This will almost certainly give you a high index value. And you can see the same thing here with nitrous oxide for anybody who's still using nitrous oxide. Another thing I think is really important to note is that these EEG indexes, they're so distilled down to this one number that we have that it fails to reveal the complexity of the jobs that we have. We do not, anesthesia is the concept, right? That is hypnosis and analgesia and akinesia and amnesia. And we're putting all of the complexity of what we do into a single number, which quite frankly is a little insulting to me and should be to the rest of you. We are not number titrators in the singular sense, but there are many reasons why somebody might have a different EEG index value because the underlying EEG changes in a variety of contexts. Here's work from Paul Garcia and his group where they've identified signatures of alpha dropout. So this is where your alpha band, your 8 to 12 hertz band, sort of disappears from the record for a bit. And they made the case that this is associated with nociception, and that when you give analgesic agents, you can actually restore this alpha activity, notably during these same times as your alpha power is decreasing, your delta power is increasing. Now, this is going to change your overall frequency composition, which is going to change your EEG index number most certainly. And while I don't have particular data, with a EEG index for this particular case, we certainly have EEG index data for the case of akinesia. Now, this is a study done in 2015, so this is 10 years ago, where they recruited awake volunteers to undergo succinylcholine and muscle relaxation and to be awake during this case. So hopefully, I think this is pretty much demonstrative of what we have. I wish I had a laser pointer, but you can see on the panel on the left, this is the EEG 3 minutes before administration of succinylcholine. It's high, the patient's awake. 1 minute after the administration of succinylcholine, it's still pretty high. Notably, patient is awake after all of this, and 6 minutes after an administration of succinylcholine, your BIS is at a range for general anesthesia. So if we can make an awake patient show a BIS number that's in the range for general anesthesia, it certainly doesn't give me confidence in the utility of this number. To further illustrate that point, in the same study, this is looking at one patient over time and how these things change across a number of, or across two BIS devices. And so here's the one patient given rocuronium now. Rocuronium administration is at minute 0. Between minute 1 and 2, that's clinical paralysis. And so what you can see is that the EMG activity that these devices are reporting does go down. That's good because the patient is paralyzed at this point. And again, remember, this patient is awake, and with a little bit of a time lag, you now see that the BIS indexes will go down to a level of appropriate general anesthesia, which would be appropriate for a surgical case. And you know what? They're not going to move in response probably to the surgical stimulus, if there was one, because they're paralyzed. But this is a bit alarming, or should be alarming. The arrow B represents tongue movement, and then SG is Sugamadex administration, and E is eye opening. And you can see that once you reverse the paralysis, look at your BIS number. It goes right back up and tells you that your awake patient is now awake. There are other sources that can affect the EEG indexes, and that's because EEG is a low voltage and it's a pretty fragile signal. And so I gave you an example of electrocautery artifact here. So this is a case that I was doing. Patient, hopefully before I even start the video, you can see that the patient's in a fairly good, alpha delta plane of anesthesia for quite some time. I'm, sort of optimizing my parameters as we're going. But on the most right-hand side of the spectrogram, you're seeing all this activity because there's electrocautery. And I tried to capture some of this in real time. So, this is the, you can hear the bovie, and you can hear that artifact, that high frequency that high frequency electrical activity. And as you do that, you can see that my spectral edges are rising during those brief moments. And as they're doing so, look at my PSI number. It's 62. And for the Massimo said line, the appropriate plane for general anesthesia is 25 to 50. Now, I didn't take this and then over-anesthetize the patient or give the patient more anesthesia because I was pretty confident the patient was where I needed them to be and it was really artifactual. But these numbers don't tell us that in isolation. Okay, there we are. Another example is that of aging. So when we age, our band power for EEG decreases for a number of reasons. Our skull gets thicker, so we filter more of that activity away. Our neurons get farther away from our skull as we have more CSF and our cortex shrinks. And when you have these changes on the spectrogram and you are getting more and more low voltage sources, this actually can affect your EEG index monitoring. Here is a demonstration of that. This is a paper a couple years ago in Frontiers Aging Neuroscience, and this is looking at elderly and young patients. Now, elderly is older than 65 and young is less than 65, but the mean age of this population was 55 total, 18 patients altogether. And on the graph on the left, you see basically increasing effect site concentrations of propofol. LOC is loss of consciousness, and so -2, -1, this is the minutes 2 and 1 before loss of consciousness. And then on the very right, you have the point of the maximal effect site concentration of propofol. And in between that fourth time point is halfway in between loss of consciousness and that maximal effect site. So you can see on the left, the propofol effect site concentration is steadily increasing, but look how this changes and dissociates between the elderly and the young. The elderly have a much higher BIS value over pretty much all of these time points than the young patients do. And that, it's something to consider is that your monitor is actually, maybe not even calibrated to age. And we have, many patients of many frail ages. And in fact, the ones we want to do this monitoring on are usually the frail and the older ones. Continuing on that theme, if you now add cognitive impairment to aging, and so now this is an experiment people did on ASA 1 and 2 patients that were all above 65 years old, but some of them had a mini mental status exam that was above 25 and some with below 25, and you see that you start to have significant differences in the BIS index values at baseline, at loss of consciousness, at gas off plus 3 minutes, plus 5 minutes, and just after extubation. All of these patients had propofol induction with remifentanil and rocuronium. So you can see, this phenomenon does track over multiple patient populations and multiple anesthetic agents. Here's another example to show the low voltage that you can see with older patients. And so this is a 74-year-old woman who underwent a posterior fusion. I took this snapshot during my case. And hopefully what you can see is that my spectral edge frequencies, and they're reading 4 and 7 right now, which, I doubt they're 4 and 7 because I can see some alpha activity, although it is low band here. What you can see in that trace and the history of it that I really want to show you is how variable it is. Because when you have such low voltage signals and you're trying to make calculations on them, small changes are going to propagate larger and larger differences later on down the road. And so in this older population, you're going to have high variability on EEG metrics. If you notice here, there's a little bit of potential burst suppression on my spectrogram, and you just got to trust me, but I promise I was looking at that time and there was no burst suppression. It's just that because you start out so low voltage and these thresholds are so low, the machine erroneously picks this up as such. And so if you're using the EEG index to make these decisions, you're going to be chasing your tail a lot in an older individual because this is going to be 40 1 minute and then it's going to be 70 the next minute and 35 the next minute. It can vary quite wildly. The last comment I want to make, or argument I want to make, is that these EEG indexes are not standardized across monitors. We've been talking about that a little bit around the bush, whereas the BIS time point is, clinical range is 40 to 60, and the PSI, the Patient Safety Index from Massimo Sedline, is 25 to 50. But here is an example of another study done in older individuals above 65. This is EEG that was collected from a Sedline, then taken and then fed back into a bunch of different monitors, including the Sedline as kind of a control, but to a Sedline, to a GE entropy module, to a BIS Vista. All right, and what I want you to note is how discordant these indexes are between each other. And also, these, for the majority of this, and this was, actual case, and there was no problem with the case. This patient did not report any awareness after the event. But if you look at what would be the appropriate clinical range for general anesthesia from a BIS, that would be in the blue rectangle right there. And you can see for a good portion of this case, this patient is inadequately anesthetized, says the index monitor. Same thing for the Sedline, which is where these data came from. Although their range is different, similarly, but again, not concordant with the others, there's a little bit of variability here. This patient would have been, qualified as under anesthetized for a good portion of their case. And so in summary, our EEG indexes are commonly discordant with our known features of EEG activity that we see in anesthetized states. These indexes are very context specific. They work better with GABAergic agents, when they were, which is kind of like how they were conceived. And they're not generalizable across anesthetic agents. And especially if you're running, multiple infusions and more clever, I would say, anesthetic plans, this might show up in discordance in these EEG monitors. These indexes do not dissociate hypnosis from things like analgesia and from akinesia. There are multiple planes on which we need to understand the neural activity. Again, these indexes are influenced by many sources. They're low voltage. They're prone to error by both physiologic artifact and non-physiologic artifact. And lastly, as I just showed you, these indexes are not standardized across the monitors. And so now we'll discuss.
Very well. Thank you to fabulous discussions. I welcome anyone to ask questions.
Hi, Martin Talbot from Montreal, Quebec. I personally do TIVA. In Canada, we have the FX site infusions available with our pumps. It explains why there is way more TIVA here in Canada. I agree with you, Dr. Savivia. There is no perfect monitor. And as an EKG will be interpreted in terms of interference from the cautery, or sometimes the EKG will read the T wave, or in the same way the EEG has to be put into the global context of the anesthesia. And you can see with all the other parameters if you are on track, or you can adjust. It's just a monitor amongst others. That's the way I use it. It's not a number. You really have to also read the leads and the
Yeah, I agree. I have a slide that I show the residents, and I take off the EEG, all the raw traces, and the EKG is among them, and the number shows that the patient is in asystole, and I say, do you trust this number? Do you think your patient's in asystole? And they say, well, I want to see the EKG. And I say, well, then why don't you want to see the EEG? But I think for some reason, we are much more comfortable with looking at EKG waveforms and those kind of time series data as opposed to looking at the EEG, and we rely so much on that index.
Yeah.
Or at least in America, it's much more.
This is not the way to use this monitor. But I think it's reasonably reliable. In the rest of the world, it's used very common with TIVA, and it has shown that it has a good track record. But yeah, that was essentially my point, just to look at the whole picture and forget the number and look at the other data from the BIS and from the other monitors. Thank you for the very interesting talk.
I don't need to comment. I think you
Yeah.
you emphasize point which I'm bringing, which I'm trying to make. Yes, sure, there's something better. Eventually, it would be developed better. But as of now, what we have, to me, it's good enough to do some type of adjustment, and we have no way, like I showed, even pulse oximeter, leave it outside and it will give you some number. People with vasoconstrictions, they give you wrong number. People, dark-skinned people, show pulse oximeter not reliable. Yet we're using it. I just want you to see that we don't need to apply some ideal kind of super criteria for this particular monitor when we easily accept the same errors, the same variability with everything else.
Hi, Rafi Vizian. Thank you very much for both of you. You put the pulse oximeter of red jello before? But you still use it. So despite the fact that I...
Oh, but probably you wouldn't have a tray, like...
Well, that
If it's if there's
cardiac
enough color.
surgery showed a 100% saturation in that, in that,
You got it,
that monitor, right?
you got
So having said that, I agree with the doctor from Montreal. A monitor is a monitor and a monitor. You just have to put everything together and interpret. So why were you using the EEG there or the BIS there? Yeah, you were not looking at the number, you were looking at the raw data. And even in raw data, I said, no, this part is the part that he is using the cautery. So it all comes down to, I don't think BIS is a very good device, but yeah, that's all we have right now. We have to think of better things, better strategy, but it is what it is.
Thank you.
Thanks for the wonderful panel. Ellen Yang from University of Washington. Just a question, because I just came out from rimimazolam point counterpoint. Do we have any data that we know that's try to, looking for the signature of rimimazolam because it's such a new drug? And if it's coming up and coming in the future, then will affect the EEG monitors utility in general?
I'm not aware. I'm kind of deal with this drug a lot. I would imagine it would be no different than midazolam. Essentially, this is the same drug, it's just shorter acting. But I don't really have. I don't remember. I don't know.
I agree.
So,
I don't know of any.
but this is actually. Let me just comment.
Actually, we have done it. I've used it multiple times with Setline. It has the perfect propofol, look.
Yeah,
propofol
like
and
expected. Yeah. It would be
Similar.
expected, right, to have similar this number.
Thank you so much.
I do have a question, Sayed, and it's for Sayed. A lot of the clinical trials of impact of using monitors and cognitive outcomes, whether we're talking about delirium, long-term cognitive outcomes, is again that the number might actually not be significant, but it is very useful because you use that as your, we kept all our patients between 40 and 60 or 25 and 50. So, because it's something measurable, right? That it's different from, you're writing a study design, like you just look at the patterns. So how would you say for new studies that are coming out, how would they put it in their methodology that is not maintained under the proprietary indexes? How would you put it in your methodology if you're designing a study?
Yeah, that's a great question. That's a question that's really challenging to answer because especially, I think it's a problem of scale. Because once you execute a trial that's going to have hundreds and thousands of patients, there has to be a way to standardize and show inter-provider, agreement to some degree, and it's difficult to make sure everybody would be trained otherwise without using a number, like that as well. If you look at the previous RCTs that have been done, or some of the major RCTs that have been done specifically with respect to delirium, originally it was using EEG versus just using end-tidal volatile concentration. And so, I think there is people have shown a nice dissociation, or I should say a delta between, several metrics by doing it that way. In particular, the balanced trial was looking at 55 versus 35 as a
metric.
this metric target. What's interesting is that the balanced trial seemed to show more of a difference with postoperative delirium and level of anesthesia, whereas the other trials that did not use a target did not show a difference in those cases. I wish there were better metrics. I wish, there could be a metric that could look at the actual quality of the EEG, but I will give you another example as some way that we might be able to get better data. We think a lot about burst suppression as a potential determinant of postoperative delirium. But if you look at all the RCTs that are out so far, with almost zero exceptions, they're using the suppression ratio that's provided by these monitors as well, which is also not necessarily that.
You gave an example.
Exactly. I mean, yeah, there was an example of false suppression right there. And so whether it's suppression that's not being reported, there have been studies that show that if you actually quantify from raw EEG the burst suppression with its relationship to postoperative delirium, you can actually see significant associations, where if you just use a suppression ratio from these machines, you will not see it. So I guess what I would say is let's collect the raw data. We can make the, make the groups as we want, but collect the raw data and use that to analyze.
Okay, so since I'm going to continue on this one. What about if, would you think the spectrogram could be used as a metric? Could, using all this technology, at any time you have 14% red and I'm a little bit colorblind, so
I think that'd be a function of how you set your parameters, because you have max and min parameters for your spectrogram for visualization. So not visualization, but I'm sure you could derive another spectrogram given the raw EEG activity if you had it.
An estimation of an estimation of an estimation.
Well, that is not necessarily that way, because the spectrogram is from the raw data itself. It's just the transformation. The further down metrics, the artifact, the EMG, the suppression ratio, the BIS, the PSI, those are more approximations. So actually, the spectrogram is as close to the raw data as you can get. It's one step away.
Okay, I'm going to leave the other, somebody ask questions, because I have one for you, Alex, too.
Okay, I don't feel deprived, I'm fine.
No, but I want to. Please.
Great talks. I really appreciate it. I'm Ben from Mayo Clinic in Jacksonville. My question is, you guys are talking about the process index number as a number, and that's what your pro-con debate was about. Yeah. You spoke about this a little bit, but can you talk about the trends and changes in that number and whether there's meaning there that maybe, with the SED line, for instance, you can actually just set it where you look at the trend of that index over time. Is there any value in that? Because even, as you said, artifact and other things are going to affect that, and it may not be to what you're necessarily looking at, but I think more than just looking at a range, if there's ups and downs, that might be meaningful. I just wanted to hear your guys' input on it.
Yeah, I would say when you use this number like anything else, if blood pressure going, go very high and BIS for whatever, so you know that a patient is light, and if at this time BIS number or whatever PSA number goes down, you know something is not right, and I would be on a cautious side and deal with blood pressure and things like that. This is not the only monitors. Give you some idea, but it's you take it as a part of overall assessment of a patient. Trend, yes, sure. If I'm infusing propofol and I see slowly it's kind of going up, I need to increase, and everything else is, eventually it will pick up as a number will start moving, but you see the trend. If it's going up, that means you need to give a little more, or decrease, or whatever. Usually, actually, it's interesting teaching point, like if, with long time infusion, prolonged infusion, you don't need as much, your dose, infusion rate should go down simply because whatever context sensitive half time, so you will see it. If you don't change this thing, you will see changes in this BIS number.
I just wanted to say it also, just so you can emphasize the fact that you were saying about if there's a lot of variability, especially if there's a low.
It's true.
Yeah, so I'm not allowed to say this because I'm the con argument, right? But yeah, I mean, these numbers are there, and for the taking, right? So I'll put the BIS or the process number in the most in the most inconspicuous place, so I rely on it the least. But if that number is fluctuating wildly, then it tells me that my metrics are probably less reliable. And so what that does to me, if nothing else, is gives me an indication that this is a case or a patient that I'm going to have to look at that raw data a little more vigilantly and be very careful with titrating my anesthetic to that end. And I know that, there's going to be, that I'm going to see a lot of discordance in certain areas.
Thank you guys.
Again, is it ideal? No, they would be improved, and eventually we learn how to interpret these psychedelic diagrams, whatever was shown. It's beautiful. Eventually we learn it, but right now we don't. I would imagine even people who are here who, most of you do some neurosurgical cases or consider yourself expert, even here, if I will ask how many people can interpret this thing, I don't know, it would be very few. So we're not there yet. Ultimately, we will get there, probably. I don't know, maybe yes, maybe no, I don't know. But one way or another, my point was using this monitor as is right now. I think the monitors have clinical value as is. Would it be better? Yes, no question. And people like Syed moving whole field in this direction. But before we all residents would be educated, it will take few years, and eventually we move from VHS to streaming. We will do that, but right now, let's use VHS. Whatever it is, it's still a usable monitor.
And just as a plug, there's a session tomorrow, if I show up to it, that's about how to interpret these EEGs a lot better.
Jeff Manning, private practice, Waco, Texas. Don't use BIS currently. I like the idea of protecting old brains from further dementia, et cetera, but are there any legal ramifications that y'all know of, either for or against the use of this technology?
For sure, for awareness. I think one slide was specifically showing that lawsuit approximately 200,000, highest in 2003, I think it was, maybe earlier,
Okay.
was 1 million.
Sorry, I missed that.
Yeah.
Okay, appreciate it.
But it's still not standard of care, so
Yeah.
you wouldn't be faulted for not using because it's not a standard monitor from at least from the ASA. That's what I would also
It's a
say.
recommendation.
It's
It's true.
It's coming.
But it's true.
Hi, I'm Kunal from UC San Francisco. Just got a question about ketamine. Just want to describe a little scenario, if that's okay. So you mentioned that you could look at the EEG, look at different parameters, and know about the depth of anesthesia. The moment you give ketamine, the EEG moves into higher frequency. Now, if that happens, then obviously your number is going to be higher. Quite often in my OR, when I'm doing spinal cases, you've got ketamine running all throughout the case, which means that when you're using propofol and few other things, your EEG is fine, number is great. The moment you put ketamine in, the number goes high.
Don't I
And
know
all
it?
throughout the case, your number is really high. Now, what do we do in that case? Because it then doesn't indicate anything about depth of anesthesia because your number is constantly high.
Right. So
And even the EEG looks really at a higher frequency. So is there any way to navigate through this?
it's like uncomforting too. Yeah, for sure. The way I navigate it is I set up the patient in a nice GABAergic alpha delta plane first.
Sure.
And I make it stable and try to titrate my doses as best as possible. Then I add the ketamine, and I know that my changes are time locked to
I get that, but in
administration of new
in
agent.
that situation, you're giving ketamine after the incision, are you?
That is correct. Well, actually, no, that's
You
not
wanna give it
necessarily
before
correct.
incision, isn't it?
I would love to. Well, actually, I give a small bolus in the very
okay.
beginning, but I try to minimize it so I can basically see a GABAergic signature first to optimize that, and then I add the ketamine, and then I know I'm kind of flying solo a bit because those numbers are just going to be, what they are.
Be anything, yeah.
And then from then, hopefully I've set it up in a place where, okay, ketamine is given, I see a new regime, but I'm pretty confident that I'm in a good plane of anesthesia, and then I can look at variations on that spectral activity, and I use that as a way to titrate. But I agree with you, it's a really uncomfortable place to be in. And when I'm doing that in a room, I don't leave the room either with the resident because I don't want to, let that
Sure, I mean, it's a very common thing with spinal surgery, you have ketamine running all throughout. So.
Yes.
Yeah, but
All right, thank you.
with all this thing, I understand ketamine is an issue, but it doesn't mean that you wouldn't use PIS or whatever, PSA in other circumstances. Of course, it's recognized ketamine is the issue, but you just know that, and in this particular case, you don't use it.
Okay, thank you.
I'm really sorry, I'll have to close the session. It's the time. Thank you very much.
Thank you. Thank you.
Thank you.